Thank you for that kind introduction. Today, my talk is about prostate cancer research, particularly focused on improving quality and quantity of life. So some key facts about prostate cancer that I'm sure this audience is aware of. Prostate cancer is the most common solid organ cancer among men in the United States, with 250,000 cases per year. Many cases, thankfully, are diagnosed with localized or regional disease, which are highly curable, thus making treatments less burdensome and improving post-treatment quality of life are very important goals for us to look at. Not all men are cured, and prostate cancer remains the second leading cause of cancer-related death among American men. However, a large group of men may experience non-lethal recurrences after initial treatment, which can be cured and salvaged with various treatments. And these treatments as well can impact the quality of life. And a new frontier, which I'll mention later in the talk, is the so-called area of oligometastatic disease. So our overarching research goals at UCLA are designed to benefit men with prostate cancer as well as their loved ones by accomplishing two goals: improving treatment-related burden and post-treatment quality of life for men treated with prostate cancer is our primary goal, and improving treatment outcomes specifically for men with aggressive disease. Radiation therapy is the standard of care among treatments of the standard of care for the treatment of prostate cancer. Historically, a course of radiation involved the delivery of small daily doses of radiation over the course of 8 or even 9 weeks. And while this was effective, it imposed a substantial burden of time in and of itself for the patient's family. Advanced technologies and a unique biology related to prostate cancer, however, could be leveraged to safely condense the course of treatment into just 5 treatments given over a span of between 5 and 10 days. Known as stereotactic body radiation, or SBRT, this form of treatment is significantly more convenient as well as more cost-effective than the older forms of radiation therapy. UCLA was a pioneer and early adapter of SBRT. So here is the kind of the radiobiology, the arcane radiobiology, I suppose I should say, around why these higher fractions and shorter fractionation courses might be better in treating prostate cancer, better to kill the cancer, and better for tolerance of the tender normal tissues surrounding the prostate. But here is a not so obvious finding associated with these large fractions of radiation that are given with stereotactic body radiation. Here's an article about gene induction in brain irradiation. Now, what could this have to do with prostate cancer? Well, what it showed is this type of data. And if you look over to the right of the 4 columns, the black lines, they're showing a radiation-induced response of things called pro-inflammatory gene expression. This is another way of saying these higher fractions of radiation stimulate the immune system, creating a cascade of proteins called cytokines. And this particular group of cytokines is beneficial in treating and curing an individual cancer in an individual patient. This led subsequently to this important lecture given by Dr. McBride, now an emeritus professor at UCLA, where he discussed the immunologic notion of danger associated with radiation. It not only has something to do with what we're going to talk about today, but also has important attributes related to the uses of immunotherapy in other tumors, such as lung cancer, melanoma, in fact, and prostate cancer as well. So subsequently, additional research was done in our labs and also labs on the East Coast, showing the same effect of this cascade of proteins that I mentioned called cytokines. And it's a matter of creating a balance, getting the right dose fraction to create this cascade of these, what they call pro-inflammatory anti-tumor proteins versus inflammatory proteins that cause excess inflammation. So initially, we began treating in this way these 5 treatments of these very high doses, and in 2013 published 1,100 cases in the literature, the article on the top. And this subsequently became almost 2,000 cases published in 2018. And what we showed in these articles is the outcomes appear to be the same as with the standard IMRT treatments of 8 or 9 weeks. The final article of 2,000 patients was a consortium of 12 separate, what we call phase 2 trials that were pulled together and have some of the longest outcomes for SBRT, with many patients followed for more than 10 years. It displayed, the information displayed excellent cure rates and equivalent outcomes when compared to the legacy forms of radiation. And it was actually cited in the National Comprehensive Cancer Network guideline set, noting that SBRT had become a standard of care by 2018 and 2019. Subsequently, 2 randomized clinical trials were performed, one in Sweden, one in the United States, where they randomized between SBRT type treatment and standard legacy IMRT treatment. These were so-called non-inferiority trials, basically showing the equivalency in terms of cure rate and side effects between the 2 treatment modalities, further validating the role of stereotactic body radiation for the treatment of prostate cancer. So basically, we take 8 to 9 weeks of radiation in the rectangles in red and condense it down to 5 to 10 days of radiation in the rectangle in blue. And we actually published an article about this in Cancer in 2016, utilizing an accounting analysis methodology called time-driven activity-based costing to understand the long and short-term costs of treating localized prostate cancer. And what we showed, with using this value-based approach to care, is the actual cost, not the reimbursement, but the actual cost of delivering the various treatments. And you can see that SBRT was the least expensive of active treatment, with, of course, active surveillance being the least expensive in terms of cost to the system. So our group has published a total, or actually more than 10 high-impact manuscripts defining some of the novel applications of SBRT, as well as many practical considerations. And important to note, the top article, which is called the SHARP Consortium. Basically, what we analyzed here is high-risk patients. The initial trials were mostly, but not entirely, but mostly low and intermediate risk patients. There were some high-risk patients in the group. But here, the SHARP trial shows 344 patients prospectively treated. And once again, it showed similar outcomes to the legacy treatments, yet at a much shorter time and a much lower cost. So a next frontier in SBRT and prostate cancer is MR-guided radiation therapy in the delivery of SBRT. Nearly all radiation therapy nowadays is delivered using a CT scan guidance, CT scanners built into the linear accelerator to help guide the treatment, called image-guided radiation therapy. However, CT, because of its inability to define differences and nuance in soft tissue, has less precision and accuracy than MRI guidance. An MRI guided machine, there are probably about 10 of them in the United States, and we were fortunate to be one of the alpha sites for this type of technology. We began to utilize this and to study whether MRI guided radiation therapy is equal to or in fact superior to CT guided radiation therapy. I'm going to show you the very first case we did. It's of interest. When we plan the patient, we do something called a simulation. We take scans, and the planned images are the images at the top. The image on the left is a slice through the patient, or an axial slice, and a sagittal slice is the image on the right. Outlined in red on both images and on further images is the prostate. The setup images, in other words, putting the patient on the table, getting an MRI scan, and localizing the patient, are on the bottom. And if you note, they look identical. So the setup is working. Here is the very first patient on the very first fraction treated. So this is a movie, a video of the MRI. Watch the gas bubble go by and push the prostate right out of the field. Here, we'll watch it again. It'll come through there. The gas bubble moving the prostate right out of the field. We were startled by this, and I must say that it didn't happen on the additional 4 fractions. The patient, I should note, did not notice that, did not pass gas or feel cramps or anything like that. So we knew that the prostate moves a lot more than we thought it did. So in the last 2 years, we began a trial we call the Mirage trial, doing a trial comparing CT-based imaging versus MRI-based imaging in the treatment of prostate cancer utilizing SBRT. And we should start to have results later this year or in early 2022. So stay tuned. Stay tuned for that. Another next frontier in radiation therapy utilizing SBRT is that utilization of SBRT after surgery. Somewhere between 30 and 40% of patients who undergo radical prostatectomy will end up having an indication for postoperative radiation therapy. However, due to the deformation and anatomical and geometrical uncertainty of the target tissues, SBRT in this setting has been technically challenging and had not generally been studied. And in further explanation, what happens is now the prostate is gone. So you define an area that we call the prostate bed, and that prostate bed is deformable depending on the motion and of the rectum and the amount of filling of the bladder and so on. And because of this, change can happen in real time during treatment. We thought that MRI guidance, where you can actually watch the treatment in real time, was a potential good solution for treatment in this situation, bringing the benefits, the biological benefits, as well as the socioeconomic benefits of SBRT to this group of patients. And we began our first trial that we called the Scimitar trial that finished earlier this year, and now have put in place a new trial that we call the Excalibur trial. I should say the Scimitar trial is being currently analyzed, but I can tell you, having treated many of these patients, that the outcomes of treatment, both in terms of side effect and control, look similar to that of more standard 8-week fractionation for postoperative radiation therapy utilizing IMRT. Another new frontier in radiation oncology in general, but specifically applied to prostate cancer, is something we call radiogenomics. Toxicity after radiation therapy is driven by the doses of radiation that the normal tissue, the bladder or rectum, receive. However, some patients appear to be more sensitive to radiation than others, and that's where this concept of radiogenomics comes up. So if, for example, you don't tolerate onions very well on your food and you ask the people who prepare your food not to cook with onions, that may be a genetic predisposition to making onions uncomfortable for you to eat. Similarly, with radiation therapy for some patients is just not well tolerated. Well, we've identified a DNA signature, a genetic signature that appears to predict for high toxicity for two types of radiation, both SBRT and more standard course. And interestingly enough, it's different DNA signatures that tell us who's at high risk for a side effect for SBRT, and different from what the DNA signature would be for IMRT. So this is up on the left is Joanne Wheatus. She's a faculty member, professor at UCLA, who is a bench scientist in her day job, but she also takes care of breast cancer patients. But did the work, her lab did the work to identify the DNA signatures associated with these higher risks of side effects. And she, along with one of our other faculty who runs our GU service, Dr. Umar Kishan, designed a trial to test and validate this DNA signature lab test. And the patients who want to get SBRT and want to sign up for the trial are tested. It's a simple cheek swab. If they come into the high risk group or a greater than 50% risk of having a significant toxicity, they are told about it. Since this is not a validated test, the patient still is informed of that and has a choice to either continue with the SBRT or undergo standard fractionation or moderate hypofractionation, where the risk is not being shown by the DNA signature. And we call this the Garuda trial. And this trial is accruing and is ongoing at this time. Again, what we're doing here is trying to validate this lab test, this genetic test, to make sure that we can offer this to patients with certainty. Another area that we're studying, and I'll just briefly go over this, is that we're looking at oligometastatic disease, or a patient has developed metastatic disease either at the time of original diagnosis or subsequent to their primary treatment, either with radical prostatectomy or with radiation. And if there is very few sites involved with metastasis, either in, let's say, lymph node or bone, we call that oligometastasis, or oligo or few metastasis. Dr. Nick Nichols, who's the chief at the VA, but also attends in Westwood at UCLA, has designed two trials, one only open at the VA, the one on the left, that basically is looking to learn more about oligometastasis. This is a basic science trial trying to learn these things. And in fact, here are the aims of these trials: to find where the metastases are coming from. There's probably multiple clones of tumors in the prostate, and what he's trying to do by RNA sequencing and DNA sequencing, trying to determine which are the areas in the prostate that are causing the metastatic disease, and then subsequently figuring out what those true primaries are that correspond to the metastatic disease. This type of information will be important in targeting therapies either radiation or hormonal-based therapies, or possibly even chemotherapy-based therapies as well. So a separate and major research interest has been looking at the differences in aggressive prostate cancers and evaluating strategy for treatment intensification. Treatment intensification, I mean increasing dose or increasing additional treatments such as hormone ablation. Here's the picture of Amar Kishan, the chief of our GU service at UCLA. He published two very important articles in 2018 and 2019. In 2018, an article in the Journal of the American Medical Association basically showed that with treatment intensification in high-risk prostate cancer, Gleason 9s and 10s, that there was significant survival benefit when there was local treatment intensification. In this study, what treatment intensification mostly meant was external beam plus a brachytherapy implant. But what it was really showing was that what you need is a higher biological effective dose for these high-risk Gleason 9 and 10 patients. And then subsequently in JAMA Oncology, the Journal of the American Medical Association has an oncology-focused journal in 2019. He identified different response rates to systemic therapy depending on the Gleason grade, breaking the conventional wisdom that shorter courses of hormonal ablation were appropriate for high risk and longer courses for, like 9s and 10s, and shorter courses of hormone ablation were appropriate for lower risk, like Gleason 8. Well, it turns out it's the other way around. It turns out the Gleason 8s do better and have similar outcome whether you give them longer courses of hormonal ablation of over a year, and appears 4 to 6 months is adequate. Whereas the higher risk patients, the Gleason 9s and 10s, do better with more than a year, possibly 18 months being the sweet spot for hormone ablation therapy. So in summary, we've established SBRT as a standard of care, and along the way, we've provided practical guidance on treatment to other treatment sites. We're in the process of evaluating MRI-guided SBRT, both in the primary prostate cancer setting and in the post-surgical, post-operative setting, use of SBRT. We're evaluating the radiogenomics to see if we can identify which patients are, the way they're built, are more associated with a risk of getting a side effect from radiation therapy, so we can put them or show them to a new direction or a different direction. We're developing a better understanding of oligometastasis as we treat these in our patients. And we're investigating the more aggressive prostate cancers, evaluating treatment intensification strategies. It's led to about 95 publications in the last 5 years, over $1 million in grants and gifts, and 4 unique paradigm-changing clinical trials that I've described to you in today's talk. I'd like to acknowledge some people who I've already mentioned in the talk. Dr. Kishan, who runs our GU service, Dr. Nichols, who is the chief at the Greater Los Angeles VA, also called the Wadsworth VA, Albert Chang, who is the vice chair for surgical services in the department and a nationally known brachytherapist, Alan Lee, another brachytherapist, surgical radiation oncologist in the department, and certainly the contributions of the department, the Johnson Comprehensive Cancer Center, and the health system, as well as supporters of the research, which include the Prostate Cancer Foundation and the American Society of Radiation Oncology. Thank you for your time, and I look forward to our discussion and questions.